So let me ask this question first before I start. At what gestational age is gestational sac seen first in pregnancy? At what gestational age on transvaginal scan? At what gestational age do we see the sac?
4 weeks, 5 days.
4 weeks, 5 days, or 12 weeks, 5 days. I couldn't hear you well.
4 weeks, 5 days.
4 weeks, 5 days. Okay, all right. Is there any person who can also who has a different one to tell us?
Please.
Martha. Martha, you are not done, but you muted yourself, so we couldn't hear you.
Yeah, I said 4 weeks.
4 weeks, exactly 4 weeks. Okay. Okay, so Charity, you said 4 weeks, 5 days. That one is for which technique? Transvaginal or transabdominal?
Transvag.
Transvag. So transabdominal is seen at when? Which gestational age?
5 weeks.
5 weeks. All right, that's fine. So the heartbeat. What gestational age do we first see the heartbeat on transabdominal scan? Who can tell me?
6 weeks.
6 weeks. Okay, on transabdominal. Fine, the 6 weeks, you are not wrong, though, but transabdominal, exactly 6 weeks. It's difficult to see heartbeat unless it goes to, let's say, 6 weeks, 5 days there. The machines that are not that good, 7 weeks there. So, all right, that's fine. What is the first sign of pregnancy on ultrasound?
Gestational sac.
Gestational sac. Okay, all right. So, the
Endometrium greater than 1.3.
Can you say that again? I didn't hear you well.
I said chicken endometrium greater than 1.3.
That's the first sign of pregnancy.
Yes.
Oh, okay. No, that's not the case because taking the endometrium. But were you guys not the class that I taught the the endometrial physics recently last week or so? So I mentioned the endometrial physics. We didn't talk about pregnancy, but you know very well that the secretory phase can even go beyond that 1.3 without any pregnancy. You understand? So it's not about the thickening. No, that one, no. That one is not a sign of pregnancy. Yes. If you say it's a sign of impending menstruation, fine. But thickening endometrium is not a sign of pregnancy because most conditions, some conditions, gynecological conditions can cause that. Meanwhile, the person is not pregnant. Do you understand? And even if the endometrium is thickened, It could be that fine, the person has conceived, but still there is no pregnancy, because I told you that we have differences between conception and pregnancy. Do you understand? So who can give me the difference between conception and pregnancy? We are clinicians. We are not in English. I mean, we are not doing sociology here. So we don't say that conception is the same as pregnancy. I told you, I talked to you about that. I explained it to you the last time. So who can reiterate it?
So conception is when the sperm fertilize the egg, and pregnancy is when implantation takes place.
Okay, yeah, that's fine. So yes, those are the two differences. Those are the differences. Now, for first sign, as somebody rightly said, that's the gestational sac. You understand? On ultrasound, first sign of pregnancy is gestational sac. Do you get it? The second sign will be what?
Yolk Sac.
Yolk sac. And the third sign will be what?
The fetus.
You say heartbeat, but before heartbeat.
I didn't say. I was
Oh,
talking
okay.
to someone.
Oh, okay. So somebody said fetus. Before a fetus will come, what will precede it? There should be something before the fetus.
The Yolk Sac.
Pole.
Somebody has said the yolk sac. The yolk sac is the second, sign of pregnancy. What will be the third sign? And somebody said fetus, but I'm saying that something will come before the fetus.
Fetal Pole.
Fetal Pole.
Fetal pole. That's it, because you cannot jump from gestation, yolk sac to fetus. No, it doesn't work that way. You understand? A fetus, like we give the name fetus when the pregnancy is 9 weeks. In some books, 8 weeks. But it's better to refer to it as a fetus when it's 9 weeks. All right. Now, I'll close a bit early, so I may have to fix another time for us to meet again and finish with it, because I also have class exactly 7. Please, when it's 6:45, remind me. Like prompt me so that I stop. So when we see first trimester ultrasound, I think I've just given you the overview. You understand? So from the first time you get pregnant, or let's say you conceive, to 12 weeks 6 days, that's first trimester. You understand? Because the pregnancy is divided into 3 main divisions. So we call them trimesters. Call them trimesters. And those trimesters, when we pick the first trimester, the first trime starts from, let's say, 0 day of pregnancy to 12 weeks plus 6 days. Yes. The second trimester will start from, you see, from 12 weeks plus 6 days, you go to what?
13 weeks.
13 to what? Those who have done it.
26.
26 weeks plus oh, 6 days. Okay, what about the third trimester? The third trim starts from 27 to what? 40 weeks. So the division is like 13, 13, 13. That's how it is. But it should have been what? Yeah, 13 plus 27 is what? 40, right?
Yes, sir.
Okay. So this is how the pregnancy have been divided into. Now, any pregnancy that goes beyond 40 weeks, what's the name given to that? Any pregnancy that goes beyond 40 weeks. So when the GA is
Post-it.
okay, yeah, that's a post date pregnancy. So when the GA is greater than 40 weeks, even though some school of thoughts are saying that it should be 42 weeks. 42 weeks, like above 42 weeks before we say it's post date. But the ultrasound machine, once the gestational age is 40 weeks, it will not add up anymore. It ends at 40 weeks. Do you understand? It ends up at 40 weeks. If the head, let's say the head is like this, and you are measuring, you measure up to this place, and it has already given you 40 weeks. When you continue from that place to the to capture the rest of the head like this, no age will be added because it has ended there. That's how the machine has been configured, that if it is going beyond 40 weeks, that means it's post date. So if your 40 weeks is ending somewhere here, it means that the rest of the measurement will not be added. So you have to find a way and measure that alone. Maybe if you get 3 weeks or 4 weeks, you add you added up to what you got when you measured up to this place. You understand? So that it will be, let's say, 43 weeks, 40 something. You understand? But the machine itself, once it reaches 40 weeks on the screen, wherever you want to extend your calipers to, there will be no addition of gestational age. It will end there. Do you understand? So on the ultrasound machine, any gestational age, and even in our clinical practice, any gestational age exceeding 40 weeks, which is what, 10 months, is regarded as what? Post date. Post date. Okay. Now, prenatal evaluation. Prenatal evaluation is usually possible 4 weeks after fertilization. 4 weeks after fertilization. That means that at 4 weeks, you can use transvaginal ultrasound to visualize the gestational sac. At 4 weeks, exactly 4 weeks, yes, not plus 1 day or 2 days, exactly 4 weeks, transvaginal ultrasound is able to visualize the sac, even though it will be tiny. But it will be larger than for transabdominal. At 4 weeks, it's difficult to see the sac. Why? Who can tell me? Why is it that transvaginal can see it at exactly 4 weeks, but transabdominal finds it difficult to see at 4 weeks? Any idea? Oh, those who have done first trimester scan, you are telling me you don't know this? Hey, really?
Definitely, because vagina, the probe is inserted into the vagina.
Still, you haven't really said. I mean, giving me the answer. Like, I mean, what happens that makes the transvaginal able to see the gestational sac at 4 weeks, but transabdominal, it can't. Like, it finds it difficult to see it at exactly 4 weeks, unless there are some days added. Charity, your class, you are not talking. Talk.
The,
You guys said you have done it. So let me know why.
transverse is just so for the transverse, they just insert it into the uterus, but for the transabdominal, it has to penetrate to other things before it go. But the transverse is just inserted through the uterus. That's it.
Inserted through the uterus. Are you sure?
Inserted into the uterus, but
Uterus.
for the
Are you sure? It's
so
inserted through the uterus. Are you sure?
I said into the uterus.
Into
So
the uterus.
trans.
No, like
Close to the uterus. Close to the uterus.
so it is inserted into what? It's inserted into something, not the uterus.
The endometrium,
No.
the
Why?
vagina.
The vagina, as you are mentioning transvaginal, and you are saying uterus. Why? So it doesn't go into the uterus, oh, please. You insert it into the vagina so that the tip of it will touch the cervix. It doesn't enter the uterus. Mm? So it means that it is getting closer to the uterus. So once it touches the cervix is part of the uterus. So it doesn't really, the beam just fire through the uterus straight away and you see everything clear because it gets closer to it. But the transabdominal, we have about 9 layers of the abdomen. The waves will have to maneuver their way through all the 9 layers. And by the time they will get to the uterus is an internal organ. By that time, most of the waves would have been lost. Do you understand? So it's difficult to pick gestational sac up at 4 weeks on trans abdominal. But transvag is very easy to do that. You understand? Okay. So evaluation by ultrasound is dated from the first day of the last menstrual period, which is the gestational age. What is the first day of your last menses? What term is given to that? Who knows? The first day of your last menses. Oh, no one knows.
LMP.
Last menstrual period. That is LMP. Good. A gestational sac can usually be identified at 5 weeks, and it's an early indication of an intrauterine pregnancy. Yes. So by 5 weeks, whether transvag or transabdominal, you can see gestational sac. But I'm saying that at 4 weeks, it is strictly transvaginal. At 4 weeks, strictly transvaginal. So take note of it. Okay. Now, first trimester scanning can be performed using either abdominal approach and vaginal approach. I've talked about this, right? So abdominal approach, you perform with a full maternal bladder. Is Habakkuk and his people here? Because you guys are the reason why we are going back to the first trimester.
Yes, sir.
Yes, sir.
Okay. All right. So you have, if you don't understand anything, you tell me because you are not going to do it again. All right. So first trimester scanning can be performed using either abdominal approach or vaginal approach. So for the abdominal approach, which we talked about some few seconds ago, performed with full maternal bladder. You understand? I've talked about this to all of you with FIRST during our FIRST sessions. Yes, if you want to see something posterior to a structure, there should be what? An anechoic structure anterior, so that it will create posterior acoustic enhancement on that structure so you can see. So on transabdominal approach, you need full maternal bladder. The bladder must be filled. It provides a wider field of view, provides the greater depth of view. Yes, because it's transabdominal. You are using curvilinear probe, which has a very wide field of view. Do you understand? And the bladder must be full because you need to see the uterus and see it well, anything inside. Now, for the vaginal approach, it's performed with the bladder empty. If with this approach, vaginal approach, if the bladder is filled, it can even compress the cervix and put pressure on the uterus. We don't need that because the beam is not passing through the bladder. We are inserting the probe, so we don't need the bladder there. But it is very clear and detailed. Performed with the bladder empty gives a much greater resolution with much of fine details. You understand? So in circumstances where both approaches are readily available, you see, in our society, Ghana here, you can visit a lot of facilities. They only have transabdominal probes around. They don't have transvag. And the facilities that have transvag too, maybe the person over there is not using it. Do you understand? So it has been like always transabdominal, transabdominal, transabdominal. But the big facilities, yes, they do the transvag. You can work and go for your, internship and attachment and co. Your boss may never use transvag. Is there too, but that person may not use. That's the big facilities. Most facilities, if you pick 10 facilities now, maybe 1 or 2 are having transvaginal probes. And that is the one that will give you fine details. It's so powerful, but people don't like using it. And you see, for transvag, it also comes with medical legal issues. So if you are going to do transvag on someone, you know very well that there should be a chaperone. When we say a chaperone, someone who will come and serve as a witness. Yes, there should be a chaperone over there. Even transabdominal, you still need a chaperone, but the transvaginal is a must. It's a must. The person has to also consent. The person has to give a consent. You understand? Understand. Sometimes verbal or oral consent is fine. Yes, if you are having your chaperone around. Sometimes too, it should be written consent. They type and then the person will read and sign that, oh, I understand all the complications and everything associated with the transvag. It's for my own good, so and so. So I consent to it, and then the person will sign. But before the person will sign, you have to explain everything to the person. You understand? Yeah. We don't do transvag when the person is a virgin too. And when the person is a virgin, what are you looking for in the first place? Because we do transvag to really focus on the uterus. If you're looking for the ureters, you can go endorectal. Yes, the transvaginal probes are also used for the anal scans or rectal scans. Let me say it that way, because you can also insert it into the anus and check the prostate, ureters, and the rest. You understand? So that is for the transvaginal side. It is in a setting that we have both transvag and transabdominal. We prefer the transvaginal because it's very powerful. It gives fine details. But we don't get it all the time like that. No, there are few instances that sonographers will use transvag, especially when we are suspecting ectopic and we can't see it with a transabdominal. Then you have no option than to go transvag. But that one, if the person tells you that I am a virgin, even though you know that pregnancy test is positive, this person is saying I'm a virgin. That is all. You cannot do it. So you have to understand the patient. If you force yourself and do it, you can be sued. Okay. Now, the patient is scanned in the normal examination position, dorsal lithotomy, with her feet secure in stirrups and her perineum even with the end of the examination bed. If you don't know lithotomy, dorsal type, please, you can go on Google and check. These are just positioning, how you position the person. You understand? And this is for the transvaginal. Dorsal lithotomy, like you are lying on your back. The normal way that you lie for any scan, but this time around, you are going to lift your leg and then flex at the knee on the bed. I don't know how to teach you, but it's simple. It's like you are lying at your back and your legs are flexed on the bed. They are flexed at the knee on the bed. So it's simple. And then you are only looking for the vagina. Do you understand? So you don't expose the person unnecessarily. You are doing transvaginal scan and you have exposed the person's breast, abdomen, every part. No, please, we don't do that. You only expose where you need. So all the other parts we cover with linen or bed sheet or something. So please, now for trans vag, what you do is that you have to have a condom. Do you understand? You have to have a condom, and the condom. What happens is that you just put your gel in the condom, and then you insert your probe into the condom, or you apply your gel on the tip of the probe first before you insert it into the condom. There, it's all good, any of them. So once you are done, you see condoms already have lubricant, right, around it. We are all adults. No one is a kid here. So we are aware that condoms have lubricants, like oil. So if it is there, you think it's okay, fine. But I always advise that you apply some lubricant again. Yes, on the condom or at the introitus, yes, entrance of the vag, and then you can easily insert it. Yeah, so you have to take note of that. You see, once you are done with the scan, the condom should be disposed and the probe should be disinfected. The probe should be disinfected. Somebody is writing something. Please, can the transvaginal ultrasound be performed while the person is bleeding? It's contraindicated. If the person is bleeding, we mostly do not want to do transvaginal scan unless that's the only option. Unless that's the only option. So it's one way or the other contraindicated. Okay, so you visualize the longitudinal plane of the uterus. You know how to capture the uterus, right? How to capture the uterus. We capture it, divide the screen into two. We capture here longitudinal, here transverse, isn't it? Then the longitudinal, you measure it 2 dimensions, isn't it? The transverse 1 dimension. I hope you guys are aware of what I'm talking about. Or you don't know how the uterus is captured.
Yes,
Sir, we know.
Okay. So you measure from here to this place, that is on longitudinal here to this place also, and the transverse you go once. That's how it is. So it is BB mode. BB mode, and then you get your uterine measurement, the 3 dimensions. The machine will give it to you once you are done with the measurement, and then it will give you the volume also in cm cube. Not all machines will give you the volume. Some machines you have to calculate it yourself. So this is how you are going to capture it. And then you measure as I have done. So sagittal is the same as longitudinal. Sagittal is the same as what? Longitudinal. So if it is like this, then the transverse is like this. So here is sagittal, here is transverse. Transverse. So the screen is divided B, B, you understand? So here is measured up to this place, here is measured up to this place, then here is measured up to this place. So you get your 3 dimensions, right? Okay, so the 3 dimensions, the machine is going to give you a volume. Maybe the volume is 100 cm cube, like this. Yes, the machine will give it to you. But the machines that don't give volume, you have to calculate it yourself. So if you are calculating it, let's say this one, you got 8.2 cm, and here you got 3.7 cm, and here you got 3.9 cm. How are you going to calculate the volume for this? Who can tell me the volume? Oh, what?
So you multiply of them
Uh-huh.
and multiply it again by 0.52.
So 8.2 centimeters times 3.9 centimeters times 3.7 centimeters times 0.52. That is the formula. So the value you get is what? The volume. So let's say you are getting 98.4. That's the volume. So what's the unit for volume? Cm cube or what? Cm cube or ml or cc. Any of them. ml is milliliters. cc is also cubic centimeters. Do you understand? So that is how it is done. So the normal uterine volume, less than it is less than 100 cubic centimeters in people who haven't given birth before. Nulliparous, someone who hasn't given birth before. The uterine size, the volume should be less than 100. Then those people who are multiparous, they have been giving birth to multiple children, maybe 3, 4, 5, or even 2. It should be less than 125 cubic centimeters, because the uterus, once you are pregnant and the fetus is growing, it stretches like that. So since the person has given birth to multiple, then definitely it should go beyond the nulliparous. So that's less than 125, less than, not above, less than 125. Okay. So you have to identify also, if present, the gestational sac, the yolk sac, fetus, or presence or absence of fetal movement and fetal heartbeat. Yes, you are scanning the uterus, so you're looking for everything inside. Anything, you have to look for it. Okay. Now, after the uterus is evaluated by sweeping up and down, side to side, you see, that's how we scan. You don't stand at one point. Sweep slowly from left. You have to stand in the middle, sweep to the right, sweep to the left. Afterwards, you can sweep back, and then you sweep down, you sweep up. That's what you do. Then when you are done with that, you have, you have fair idea what you have seen already. When you are done, then you are now coming to focus on what you are looking for. So you sweep around. the ovaries are identified and evaluated. Yes. Once you are done checking the uterus and you are sure that, oh, the uterus is fine, you come to the ovaries because it's first trimester. If it's second trimester, we don't really need the ovary. But if you are scanning and you see an abnormality in the ovary, you have to report in second and third trimesters. But mostly for late second trimester to the third trim, the fetus is big, so mostly it's difficult to even see the ovaries. They compress the pelvic. It compresses the pelvic structures. Now, the ovaries are identified and evaluated. The ovaries are usually located just anterior to the iliac vessels. Okay. Document important views and measurement on film or electronically. That means that you have to write your report. Either you type or use a pen, anything. So that's the documentation of your findings. Some people, some machines, you can use that same machine to type the report and print, but it's delays. So it's better if you have a laptop and or any desktop computer there or something, or you write. It's all fine. Yeah. For a computer, if it's there, it makes the work easier because you have the format already. So you just input the details inside and you print. So within few minutes you are done. But the writing, you write and write and write. Okay. So the gestational sac is the earliest sonographic finding in pregnancy. That's the first sign of pregnancy. It appears as what? Echogenic. That means that bright echoes ring surrounding the sonolucent center. When we say sonolucent, it means black. Black on ultrasound. Sonolucent means black. Now, gestational sac has what? Bright echoes around it. Around it's like a ring, but the walls of that ring is white. That's the bright echoes. That's why we say it appears as echogenic, meaning bright echoes. But the inside is black. Why is inside black? The inside contains what? Why is it black? It contains what?
Fluid.
Can you come again, please?
Fluid.
Fluid, okay. Good. So who knows that fluid? What fluid is that in the sac?
Sir, amniotic fluid.
Amniotic fluid. Amniotic fluid, because the chorion and the amnion make up the gestational sac. So it is what? Amniotic fluid. So gestational sac is like this. There is the chorion. Then within the chorion, there is a structure. And that's the amnion. You understand? So the amnion contains the amniotic fluid here. And that is where the yolk sac will also come up. And the rest will follow. Okay. So ectopic pregnancies can also have gestational sac identified with ultrasound. Yes, even though the pregnancy is not within the endometrial cavity. Yeah. So if the gestational sac is found in the tubes, the fallopian tubes, and the tube is not ruptured yet, you see the gestational sac in the tube. Do you understand? You see the sac in the tube. And I wouldn't confuse you here because this is first trimester. Some people are now starting, so we will move gradually. When we get to a topic, we'll talk about that one. So the gestational sac appears at about 4 weeks. 4 weeks what? Gestational age. That's transvaginal, isn't it? Transvaginal. Every day it grows about 1 mm a day through the 9th week of pregnancy. Yes, it grows 1 mm a day through the 9th week. of pregnancy. Or, the gestational sac size may be determined by measuring the largest diameter or the mean of the three diameters. Let me draw something for you. The largest diameter here is called, please, what is the parameter used to measure gestational sac? Who can tell me? Obstetric parameter for measuring gestational sac. What's the name? This one, the moment I mention, you tell me, because you are many here who have done it. Hey, okay.
Sac diameter.
GSD.
So gestational sac diameter, which we call GSD. GSD means that this is the gestational sac, right? So if you want to measure the sac, you either measure from top to down or right to left, like this. So you go and select GS on the machine and you measure straight, and it will give you on the screen maybe 4 weeks plus 2 days on the screen. It will give it to you. Do you understand? So if you're using GSD, gestational sac diameter, you measure it once. You capture the sac only one, and you measure. But we are going to the mean sac diameter too. Francis.
Sir, please, my question is, in measuring the gestational sac diameter, when you measure from, we measure it from at the diameter level, and then from top to down, are you going to get the same EDD
So
or
yeah,
measurement?
so you see, it depends on how you captured the sac. That's why we always advise that you make sure the sac is as round as possible before you freeze the machine. Do you understand? So if you get the sac like this, and you measure this, don't you think the measurement will be wrong? Because if you measure from here to this place, it will overdate the pregnancy. If you measure from here to this place, it will underdate the pregnancy. Do you understand? I hope you understand what I mean.
Yes, sir. Yes, sir.
Uh-huh.
I get you.
So yeah, so it has to be round as possible. So you have to exert pressure. It's not like when the person comes, you are exerting pressure, the pregnancy will be terminated. No, you need to exert pressure, but not pressure that will cause pain to the person. You understand? Exert enough pressure, adequate pressure that can cause the uterus to mold the sac in a way that the sac will be round for you. And as you are doing it, you will see the moment you get it rounded, you freeze. So you don't capture a sac that will be like this one. When you measure, anyhow you measure, you get it wrong. So it should be like this. If the sac is like this one here, whether you measure top to down, left to right, they are all the same. Do you understand? But there are some instances that whatever you do, you wouldn't get it too round. So in that case, if it is, let's say, it's like this, you can still measure it from top to down. If it is, let's say, I want to draw something. If it's like this, if it's like this one like this, you can, the moment you see it like this, that you are not getting it to be round for you, then if your machine has the MSD, you have to go and use the MSD instead. There are some machines that has the JSD and MSD, but most machines have only one of them, only one. So if your machine is having only JSD, it means that you cannot capture this twice. You understand? You have to capture it only one, and you measure it like this one. That's for the GSD. That's why you call it gestational sac diameter, just one measurement. So if you get it like this way, you can unfreeze and try to capture again. So if you try and you are still not getting it round, then you have no option than to use the longest diameter. Do you understand?
Yes, sir.
But what we normally want is the MSD. But you have to check your machine if the machine has the MSD. Once you press the obstetric table, you see all of them. Maybe GSD, MSD, CRL, BPD, HC, like that. They'll be listed. So if your machine has MSD, it's likely that it wouldn't have the GSD because we use both of them for gestational sac. But some machines will have both. Few machines have both. In that case,
Okay.
the MSD, you capture the gestational sac. You capture it in two, like you divide the screen into two, then you capture the sac on longitudinal and capture the same sac on transverse. That's the MSD. We call it mean sac diameter. So the reason why it is mean is that the same gestational sac, you divide the screen into two like this. Capture the sac on longitudinal, you can get it a bit elongated like this. On transverse, more round. So you label sagittal. Sagittal is the same as longitudinal, then transverse. So you go and select your MSD on the machine. Then you measure the longitudinal, you measure it twice, from left to right here, from top to down here. And the transverse, you measure it once, left to right, or top to down. They are all okay, but once, one measurement. So when you are done, you will see all the 3 dimensions written there. Maybe 3.1 mm, 3.2 mm, maybe 3.8 mm. It will be written there on the screen for you. And it will add, like it will do the average of it and give you the gestational age. So you see that JA is equal to, then it gives you the gestational age. It will add all these measurements together and divide by the number, which is 3, because it is 3 dimensions. So it will add all this and divide by 3. And then give you the approximated gestational age. The machine will give it to you. You are not going to do any calculation. The machine will give it to you. Once you have done measurement, the gestational age is there. So, but it will be mean sac diameter gestational, not GS. But we expect that the GS and the MSD are almost the same because it's the same gestational sac that we are measuring. But since the MSD deals with the average, the mean of the values, we tend to like the MSD more than the GSD. You understand? But if your machine doesn't have the MSD, just use your GSD and measure it once and go your way. But make sure the gestational sac is always as like when you capture, it should be round as possible. As round as possible. Do you understand? So that's how it is. All right. That's the mean of the 3 diameters. That's the mean sac diameter. So your ability to identify an early gestational sac will depend on many factors, including capabilities of the ultrasound equipment. So you see, I always say this. Maybe not your class, I don't know, but I always say that if you have money, buy proper and better and powerful machines. Don't go and buy a machine for 10K and then you think you have ultrasound machine. No, buy good machines. So capabilities of the ultrasound equipment, you understand? Approach, vaginal or abdominal, that also influences you seeing the sac well or early. Experience, yes, you can go and stand on a machine and you are not seeing anything. Yes, your boss will come and stand there. Just the moment he or she gets the probe and press, it is there. And you have stood there for 20 minutes. Boss, I'm not seeing anything. I'm not seeing anything. But the thing is there. Experience. How to press, how to exert some pressures, and how to know that, oh, here I don't have to press deep. Here I have to press, I have to tilt the probe like this. It's experience. Somebody can stand there on transabdominal, capturing the prostate and can take 10 minutes. The person is not seeing the prostate. But you come and hold the probe, in just a second, the prostate is there clearly because you are experienced. That's why experience counts when it comes to ultrasound. Orientation of the uterus, generally it is easier to see if the uterus is anti-flex, retroflex. We have done this. I think last week or so, I taught the second semester regular students. Yes, I taught you guys. And for the second semester weekend students, Bayabati, I'm sure by now he has taught you because it is the first presentation that you are doing. Is the first topic in I think gynecology. Is gynecological pelvic diseases? Yeah. So that is it. Antiflex, retroflex, you will be able to know. You will be able to know when you put the probe, then you are scanning. And mostly those with the retroflex you try or uteruses, they some of them have difficulty in conception. It's not like it is abnormal. It's okay. It's a normal variant. But sometimes during sex and the man is about to ejaculate, the woman has to be on top of the man. Yes, and be in that same position for about 30 minutes before getting up after the sex. Yes, because of the positioning of the uterus. Now, while a gestational sac is sometimes seen as early as during the 4th week of gestation, it may not be seen until the end of the 5th week when the serum beta HCG level have risen to 1,000 to 1,500 milliliters international unit. Now, what we are saying is that even though we expect that pregnancies are seen on transvag at 4 weeks, it doesn't mean that every person at 4 weeks is a must. You have to see it. No, we have different physiological activities in our system. Yes, even though we expect that a good number of people at 4 weeks, the transvag has to see gestational sac, but there are some people that 4 weeks has come. They have come, but still you are not seeing the sac. She's not bleeding too, and it's not ectopic too. So you have to give another 1 week, and then you pick it up. You understand? All right. So this is Gen S, not S Gen. Yes, the labeling, the person turned it because they are all downloaded images. This is Gen S, not S Gen. Gen S is what? What structure is this?
Gestational sac.
Gestational sac.
Gestational sac, good. So that was at 4 weeks. So check the 4 weeks. Very tiny, isn't it? Yes. Now let's come to 5 weeks. Have you seen the 5 weeks? Gestational sac is in there. What is inside the gestational sac?
The Yolk Sac.
Exactly. So the first semesters, you can see the black, the big black. That's the gestational sac. But the one inside, which is round with whitish borders, is called Yolk Sac. And Yolk Sac is seen at 5 weeks on transvaginal scan. Listen, on transvaginal, at 4 weeks, gestational sac has to be seen. Transvaginal, I'm talking about transvaginal, at 4 weeks, gestational sac has to be seen. 5 weeks, the next sign of pregnancy, which is Yolk Sac, has to be seen. 6 weeks, fetal pole has to be seen. Please take note too. Fetal pole is the 3rd sign of pregnancy. It has to be seen at 6 weeks. By 6 weeks, 5 days or so, the heartbeat will be seen on transvaginal scan. Now, when we come to transabdominal, it starts from 5 weeks. So 5 weeks, the first sign will be seen, which is gestational sac. 6 weeks, the second sign, which is Yolk Sac, will be seen. 7 weeks, that's where we see the fetal pole with heartbeat. Do you understand the differences? So please, if you think you'll be confused, just add 1 week, 1 week, 1 week to the transvag, and you get the transabdominal. Simple. The transvag is seen at 4 weeks. If you add 1 week, you see the second sign, which is Yolk Sac. You add 1 week, you see the third sign, which is fetal pole. Even though the fetal pole sometimes it's 5 days. 5 days being added to 6 weeks, you may see the fetal pole. But it confuses people. So we say 1 week. That means by 6 weeks, right? 6 weeks on transvag, you see the fetal pole, right? But for trans abdominal, it is 7 weeks. 7 weeks. So if you are starting from 4 weeks, the first sign, 5 weeks, second sign, 6 weeks, third sign, that's transvaginal. Transabdominal start from 5 weeks. First sign, which is the gestational sac, 6 weeks. Second sign, which is the yolk sac, 7 weeks. Third sign, which is the fetal pole with the heartbeat. Once you see fetal pole, you must see heartbeat. Sometimes the fetal pole is so tiny, like not even sometimes, all the time, it is tiny. So you have to zoom, use your depth settings or zoom settings to make the image big so that you can appreciate the beating, because the heart is beating, but it's very tiny. You may not see it and appreciate it. So you have to zoom the image. So in practical exam, sometimes that's what we do. We know the heart is beating in there, but you come and stand there and tell us that you don't see heartbeat. It means all that we taught you in physics, that when you capture something, a small zoom, let it be big. You didn't listen. Okay, let's move to the next one. Now, have you seen the structure on the screen? You see, this is the gestational sac, right? The first semesters, are you seeing the gestational sac? What structure is this?
Yes, sir.
First semesters, what structure is this? There is this structure and there is this structure. They are two, they are not the same. So this structure is the embryo. This embryo, you see heart here beating, like it's beating, like, and it's so fast. It's beating over here. The heart will be beating. Then this is the yolk sac attached. So they are not the same. They are different structures over there. So that's an embryo. Have you seen how the person has zoomed the image? The image is zoomed. This thing is very tiny inside, but the image is really zoomed. That's how we capture first trim image. Okay. So when we say crown ramp length is the measurement we use for what? Who can tell me? Is the measurement we use for what? Crown ramp length is measurement used for what?
Sir, please, it's used to date the fetus.
Exactly. So it's used to date the from the fetal pole up to 12 weeks plus 6 days. Please, anytime you hear crown ramp length, we use it in first trimester, but we use it when there is fetal pole or fetus in there. The moment the embryo or the fetal, embryo is the same as fetal pole, please. The moment embryo or the fetal pole appears, we don't use gestational sac diameter anymore. We don't use mean sac diameter anymore. We forgo them and we now restrict ourselves to what? Crown ramp length. It is on the machine. We call it CRL. It's on the machine. CRL. We use that for what? The fetal pole or embryo or the fetus. But it shouldn't go beyond 13 weeks. Because once we get to 13 weeks, we are in the second trimester. We have second and third trimesters have their own measurement. It's not part of the first trimester. I'm saying the first trimester, we use 3 main measurements: gestational sac diameter, mean sac diameter, and what? Crown ramp length. Gestational sac diameter and mean sac diameter are for gestational sac alone. The moment embryo comes in, then we ignore the mean sac diameter and gestational sac diameter. And we now restrict ourselves to what? The CRL, crown ramp length. I hope it is clear. Okay. Now, the yolk sac can also be measured, but the yolk sac, some machines have its parameter YS. If you see YS, it means yolk sac, but many machines don't have it. So that one, you just go and choose your caliper. The caliper, and you come and stand here. You come and stand here and you measure like that. And you get the yolk sac. This image is zoomed. So when I get a correct one, it's too zoomed. It's too zoomed. So maybe it's a bit blur kind of thing on your eyes. Let's move. But we measure the yolk sac. We will get there. Yes, it's a subtopic there. Yolk sac, once you measure and it gets to 6 mm and above, the pregnancy is failing. Yolk sac should always be less than 6 mm. Okay, so the location of the sac should be documented. The embryo should be identified and crown ramp length recorded. Please, if the location of the gestational sac is in the fallopian tube, what do you think is happening? Who can tell me?
Sir, please, the question again.
If the location of the gestational sac is in the fallopian tube, what is happening? Like, what is it?
Ectopic pregnancy.
Ectopic pregnancy. Okay, ectopic pregnancy. That's it. That's why the first trimester, when you're writing a report, location, gestation,
that would be ectopic pregnancy.
Yeah, location is very important. So location, you write, if it is in the endometrium, you write intrauterine. You understand, intrauterine. Then the embryo should be identified and the crown ramp length recorded. So if there is an embryo, identify it and measure and write the crown ramp length. Presence or absence of fetal life should be reported. If there is embryo in there, check if heartbeat is there. Please, at 7 weeks, if you don't see heartbeat, don't go and write that the embryo is there though. Please wait. Give another week for the person to repeat scan. Sometimes the heartbeat is there, but you are not seeing it. So you wait for it to grow small again. Like add up some growth. Like 1 week is enough for you to see heartbeat clearly. So if 7 weeks you don't see heartbeat, wait for 8 weeks and then you will see the heartbeat. If there is no heartbeat at 8 weeks, then the pregnancy has failed. Fetal number should be documented. Yes, when you scanned, did you see 2 gestational sacs? Did you see 1 gestational sac with 2 fetal poles inside? What did you see? If it's 1, you write single. If it's 2, twins. But the twins, we have different types of twins, which we will talk about. Yes, we will talk about. I think, yes, we will talk about it. If by then Sir Williams will still not be here, then we will talk about that. So evaluation of the uterus. Evaluation of the you have to also evaluate the uterus, including the cervix. Check every part of the uterus. Check the ovaries. That's at the adnexal area. Let me see all the areas around the uterus where the ovaries and the tubes and the fallopian tubes are. We call those places what adnexal regions. So you check those places to see if there is any mass in the ovary, anything. You understand? Yolk sac, as the pregnancy advances, the next structure to become visible to ultrasound is what? 634 already. To become visible on ultrasound is the yolk sac. The yolk sac is round. It is round. Take notes. I've shown you some. Sonolucent. I explained the meaning of sonolucent, meaning the thing is black. It has the inside is black, but the outside has what? Bright rim. So rim. So you see that the yolk sac has a black inside, which means it means what? It contains fluid. And then the wall or the ring is bright. That is white. So it appears like the gestational sac. Same. However, the yolk sac is small as compared to the sac, the gestational sac. So it first appears during the 5th week of pregnancy. That is transvaginal scan. Grows to be no longer or larger than what? 6 mm. As I said, it shouldn't exceed 6 mm. The yolk sac larger than 6 mm are usually indicative of what? Abnormal pregnancy. The pregnancy is failing. Failure to identify with transverse, a yolk sac, when gestational sac has grown to 12 mm is also usually indicative of a failed pregnancy. So when you measure the gestational sac, once you have the sac like this, and you measure, the moment you measure, it will give you the length of the sac. So it will give you gestational sac, then the length will follow, maybe 10.2 mm, like that. You understand? But we are saying that when you measure the gestational sac and you get 12, mostly greater than 12 mm, like this, and you don't see the yolk sac inside, that means that the gestational sac has become big enough to have the yolk sac inside. But if the sac is measuring about 12 or more, without the yolk sac seen inside, is usually also indicative of a failed pregnancy. And that's at the early stages. We have a bit of late stages in first trimester where we have something called blighted ovum or anembryonic gestation, which I'll talk about soon. Okay. So yolk sacs that are moving within the gestational sac or floating or contain echogenic material rather than sonolocent are ominous findings for pregnancy. You understand? That's another failure. That means that the yolk sac, instead of the yolk sac to remain fixed, like it shouldn't be floating, moving about, because it has a connection to the gestational sac. So it shouldn't be moving about in the gestational sac. If you see the yolk sac moving around like that, the pregnancy has failed. Also, if you see the yolk sac, instead of it to contain only black, only fluid inside, you are seeing something white also inside the yolk sac, then that means that it contains echogenic material, and that means that the pregnancy is also failing. So yolk sac is also very important. Now the heartbeat. Using endovaginal scanning, the fetal cardiac muscle begins its rhythmic contractions. And that rhythmic motion can be seen along the edge of the yolk sac. You understand? So if you see the yolk sac, definitely the fetal pole is around. Is around. If it is not there yet, definitely it will come. But all that we are saying is that where you see the yolk sac, the fetal pole is very close to it. Initially, the fetal cardiac motion has a slower rate. Around 6 weeks and some few days that you see the heartbeat, 7 weeks, you start seeing the heart motion. At that time, even though the heart is beating all right, but it's not that fast because the gestation is too young. But as the gestation advances, the heart rate increases. You understand? So at early stages, around the 6, 7 weeks, 8 weeks there, you can have the cardiac motion to be around 60 to 90 beats per minute. What is the normal fetal heart rate range? What's the normal range? I know you know, so tell me. What's the normal range?
Sir, please, from 138 to
120 to 160 beats per minute. Good. So, but early stages, it will be around 60 to 90. Yes, but from 9 weeks, it has tended to be fetus. At that time, you see that the heart rate has increased within this range, 120 to 160. Do you understand? Sometimes with normal pregnancies, the fetal heartbeat is not visible until a fetal pole of up to 4 mm in length is seen. So yes, don't worry about the 4 mm. All that we want to say is that when the pregnancy is very early, mostly you don't see the heart beat. I said it earlier that if you don't see it as 7 weeks or 6 weeks plus few days on transverge, then we have to give another week to rescan. Yeah, Zara.
Yes, please, it's about the gestational sac.
Yeah.
I've scanned the patient. You know, these are people. Most of them they do not know their LMP.
Oh yes.
So they will come. You see something like a gestational sac with this hyperechoic surroundings. I don't know if it's intra-residual sac sign, something like that, in the uterus. In fact, in the endometrium.
Okay.
So and the person has tested positive.
Okay.
But the person is not in any pain, nothing. So you may assume it's a gestational sac. So you do it, you give it to them for like 3-4 days. The person will come with severe pains. I've ever witnessed a case that the lady came with mild pains though. When I did it, I was suspecting ectopic. But then I searched the adnexia anywhere that I'm supposed to search at. Because of that, I even did abdominopelvic for the lady. I didn't see anything. I only saw that the sac I'm talking about. So I gave it to her, and then I said she should repeat scan within a week for me to rule out that topic. Like 3 days later, the lady came with severe pains, and then when she came, the pregnancy had already ruptured, and I didn't see that sac again. So I don't know. Could it be fluid collection in the endometrium, and then I did it because it was too early.
Yeah.
So I just said I saw a gestational sac. I couldn't even give a date because my machine, even if it's 2 weeks, at times you will see it in trans. So I only said I saw it, and then I said she should come and let's repeat the scan so that I would be able to give appropriate dating and add it. By 3 days later, she came, and then I saw fluid in the Mauritian patch, and then the patch of Douglas, and everywhere, meaning the pregnancy had already ruptured, of which I didn't even see it. I used those signs to pinpoint that it was ectopic. So I don't know what I saw in the uterus that looked like a gestational sac. Thank you.
I don't know if you have come up. It's common. What you're saying is very common. It's not like it's a rare thing. No, it's not rare. It's common. So the thing is that I don't know if you've come across what we call pseudo gestational sac. Like we will actually treat it. Not today, but we will treat it. Pseudo gestational sac. It occurs when there is an impending ectopic. So if the gestational sac is located at the isthmic area of the fallopian tube, sometimes it causes leakages, and the leakage will drip down because at the isthmic area, there is gravity kind of. So some may leak into the endometrium, and depending on the position of the person, some can also leak into the peritoneum. You understand? So mostly if you see that thing in the endometrium, pregnancy test positive, and you see the endometrium thickened with some fluid looking like gestational sac, we call it pseudo gestational sac. So mostly what you have to do is to diagnose it as either pseudo gestational sac, and then you query early sizes. Then you tell the person to repeat scan one week time for you to confirm if there is no pain at that time. But if there is pain, like severe tenderness and cool, it will be clear that this condition is likely to be ectopic, because anytime you see pseudo gestational sac with positive pregnancy test, thickened endometrium, it's indicative of an impending ectopic. Just that you may not pick the ectopic up, like you may not pick it on ultrasound, but that sign, that pseudogestational sac sign, is a sign for an impending ectopic. Some people can have the pseudo-gestational sac with pregnancy test negative. You understand? That is there. That one mostly is just something like a cyst that you see in the endometrium. So that is a condition. Like it's a medical issue. It's a gynecological issue. But once there is positive pregnancy test with taking the endometrium, because what I said earlier is not with taking the endometrium. Those that will not show any positive beta HCG. You understand? But they have the
Yeah,
pseudo.
it's time. It says 6:45.
And that's what I'm looking at currently. Okay. Yes. Okay, that's fine. So yes. So with yours, Zara, it happens. It's not something that is uncommon. It happens. It happens with tubal ectopics. Tubal ectopics, but not the tubal ectopic at the fimbrial end or at the infundibular end or at the ampullary end. It's mostly at the isthmic or the isthmus area or the cornual area of the fallopian tube, because it has a direct link to the endometrium. So as it is leaking, it will be dripping into the endometrium. So the endometrium is already thickened. So you may see the fluid in the sometimes tiny, small fluid, scanty. So you are likely to even think that it's a sac, since there is no pain. Do you understand? But it's ruptured because when the person went back to the house, you see, every day the sac grows 1 mm. So it grows 1 mm, 1 mm for 3 days. So it expanded that part of the tube. That's why it got ruptured subsequently. And it spilled there was leakage of blood into the peritoneum. So that's how it is. You can go and read about a pseudogestational sac creating the residual sac sign and the rest. Yeah. Okay. So yes, I think I'll have to end at the fetal pole. So please write the page for me. I'll meet you. I'll meet you again. Just reserve your question because they'll start joining my link soon. We are using this link for my class. Okay. So please. Okay, wait, let me see. Dr. Ransford is available in the lecture hall. All right. So let's end it here.
Please, so should I write the time for Mr. Williams?
Oh yes. You have to. You have to. I'll meet you again. I'm planning to see if I can meet you this evening. So I'll get in touch with you guys. All right. Thank you all for joining.